Now's the time to finally realize we the people must make some choices. If we want single-payer health care, now's the time to raise our voices till they hear us in the halls of Congress and behind the White House door that we're sick and tired of getting sold out and won't take it anymore.
Okay, we're kicking off. Welcome to everybody, especially those who haven't been to one of our meetings before and from places around the country. Chapter was founded in 2006. We've held mostly every month meetings with outside speakers, and we put them on our YouTube channel. So we're recording this one right now, so don't say any naughty words. I'm the coordinator, David McClanahan, and I'm running this meeting since our president and vice president are out of Washington now. And we have an exciting program, and thanks to Kathleen Myers for pulling our speakers together. First, we here in Western Washington are on the unceded ancestral lands of the Duwamish people, people that are still here and continuing to honor and bring light to their ancient heritage. Across the country, everywhere we walk, we are on indigenous land, and whether considering the past, the present, or the future. As my role as coordinator, usually I kick off about mentioning a couple of events, one recent and one in the future that you might be interested in. The first one is we had a single payer summit, which is something that pulled single payer organizations from across the Northwest together to talk about how we might collaborate and work together to push single payer healthcare for all for everyone at the local, state, and national level. And it's really worth watching that video. We had Rose Roach of Labor Campaign for Single Payer gives just an amazing talk. So that's the first video. The second one is after she spoke, there were, I think, 28 organizations and 40 some people there for a 6-hour conference that was really something we hadn't done before. But the idea was to collaborate, bring people together, and all of those organizations were single payer organizations, basically, although some of them may have other things that they're doing. So these are the major organizations in the Seattle area that co-sponsored the summit, 28 organizations and 40 some people. But we didn't want more than 1 or 2 people from each organization because we didn't want to overrun it and we wanted to keep focused. What's coming up and coming out of that is, quote, die-in rally that we're going to have at the Seattle Federal Building on September 30th. Across the country, PNHP National is focusing on September 30th to have as many chapters that can do something to basically protect public Medicare and Medicaid. And we're going to have the Backbone Campaign. People in the Northwest may know the Black Backbone Campaign, the, quote, artful activists that are at a lot of big rallies with their huge puppets and banners, and, you know, create a scene there that is great for photos in the press. So they'll be there. Anyway, that's enough for now, and I'll turn this over to Kathleen Meyer to introduce our speakers, Dr. Mia Shim and MatIas Valenzuela.
Our speakers are the interim health officer for King County Public Health Seattle and King County, and the director of Equity and Community Partnerships. Mia Shim is our interim health officer for King County Public Health, which and that, by the way, means overseeing addiction services, homelessness services, education, and data gathering, and direct services for in gun violence and food permitting of food safety, gas, plumbing, septic lines. It's a broad responsibility. Before this, she was since 2017, she was the medical officer for Community Health Services Division, which was a lot of those direct services she was in charge of. Her education, she has a medical degree, a master's in public health. She is a clinical associate professor in the School of Medicine at UW. She has experience in sub-Saharan Africa, and MatIas Valenzuela is our Director of Equity and Public Partnerships. She's committed to improving equitable access to quality care in underserved settings. He's been with public health since 2000, and I think in 2015 became the chief of equity and community partnerships, which means, for instance, during COVID, he was in charge of community mitigation and recovery. He works with all the 8 county agencies in his position. And previous to that, he was a print journalist and a broadcaster in U.S. and abroad. He was a Fulbright professor in Nicaragua and presently an affiliate assistant professor of public health and community medicine, and serves on a lot of local national boards. So we are honored to have these 2 people with us to tell us what they see from their positions in public health and how we can work together, how we can help them with what they see as their concerns. Dr. Mia Shim would be the first to speak.
Well, thank you so much. And thank you for your kind introduction, Kathleen. First of all, I just want to say thank you so much. And I'm super grateful to join you. And you're all champions for health equity. And that's why I think you're gathering in this space. And you're committed to advancing health for everybody, especially for those who are underserved and uninsured, and all those population we need to pay attention to. So thank you so much. As Kathleen mentioned, I just started in my role as interim health officer with Dr. Jeff Duchin retiring, taking on the large responsibility as Kathleen summarized. And I've been throughout my career committed to serving those who may not have voice, and also some of the most vulnerable populations, both domestically and internationally. So I'm hoping that our presentation together with my respected colleague, MatIas, we're able to share some information that might be helpful to you and what we're doing in Public Health Seattle, King County, starting with an overview, because not a lot of people know exactly what we're doing. So we'll just give you some flavor of what we do, and then just go over some data, demographics, and inequities, including health and racial disparities, and then we'll pause for Q&A after that. And then the second half, we're going to be talking about the public health strategic plan we just developed, and it's a 5-year strategic plan that you might be interested in knowing our vision, mission, and values, and what our priorities are moving forward in the future. So that's the summary of our presentation, and then we'll stop again a second time for Q&A and comments and other discussions. MatIas, do you want to add a few things before we start?
No, I think thanks for inviting us. It is an honor to be here, also to present with my dear colleague Mia. And I know out of this group, there's such a commitment around equity and community health. So just it is an honor to be here. So thank you very much. Also, I know Emma's comment around the clinics. We can also, during the Q&A, we'd be happy to provide an update of where things are at least where things are at as of today, and they'll continue to evolve. But we can talk about that issue of the clinics. So yes. Yeah, so I was going to just provide an overview of our department. So you know how we're organized, how we're structured. I think if you've seen one health department, you've seen one health department. We're all very different. There's some core services that and foundational services that tend to be offered, but there are also a lot of differences from one jurisdiction to another. So within public health, King County, we're a staff. We serve an area of 2.3 million people. We have about 1,600 employees. And what you see on the left, that column is around really the office of director. Me and myself are part of that office, and we provide cross-cutting support and services, which are around equity and community partnerships, communications, emergency preparedness, and some of the other areas that you see there. Really, the boots on the ground and really a lot of the service provision, and plus also a lot of the prevention work and other things that we do are within our divisions. And you can see there our divisions. Community health services is the largest divisions, and that's where the clinics are, which were mentioned. But here you can see there things are more communicable disease work. It tends to be in the prevention division, and we have environmental health, health sciences, jail health services. We provide for both the downtown jail and in Kent area. There's the county has 2 jails, and we provide the health services there. You can get a taste of some of the programs out of some of those by looking here. Like health, the other one was health sciences. You can see the chronic disease and injury prevention and others. Community health services, as I said, was the largest division that we have. And then emergency medical services. This is one that a lot of health departments don't do. We run the whole medical emergency services system, including we have the paramedics and Medic One for South King County. So that's an overview of what we do. If we go to the next slide, please, Mia, you can just see a flavor of some of the things. And this is just a very quick overview of some things. You know, we do have a lab. We do have a vital statistics office around birth and death certificates. Best Starts for Kids, for example, is a voter funded initiative. It's a levy that supports prenatal and 0 to 5, and then children and young adults, and also has some place-based strategies in the county. And a lot of money goes out to community through some of those efforts. You can see some of the other things that happen here around health care for the homeless. A lot of effort around the community health services around making sure that people are enrolled in health insurance. I know this group is very interested in that. We have a very active group doing a lot of health fairs and community events. So this is just a flavor of some of the things that we do. Some are distinct to King County, but a lot of these too are kind of basic, kind of bread and butter of all health departments. You want to go to the next slide, Mia?
So King County is the most populous county in Washington State. In the past 3 years, we've continued to see growth in population diversity. In 2022, over 2.3 million people lived in King County, and this represents about 30% of Washington State's population. Most of the growth is attributable to people of color, driven in part by international migration. Now, third pie chart on the right, you see the population of young people that is now over 60% people of color. So this implies that we anticipate King County becoming even more diverse in the coming years. Now, the King County growth brings increasing cultural and linguistic diversity. And as of 2022, nearly 32% of King County residents lived in a household where a language other than English is spoken. Now, this linguistic diversity is an asset, and we are turning this strength into a service we are providing through our language access work, which MatIas oversees in his team. So we'll show you more data here. So you can see in this map, I'll first introduce a little bit before going through this slide. It's got 3 different graphs going here. So King County ranks among the top counties in country on measures of health. So we are generally a healthy region, but there are largely there are inequities by place, race, and income, which we'll go over in a moment. These are largely driven by social determinants of health, like poverty, housing, education, and their intersections with race and identity. Notably, deaths are rising, and life expectancy in King County is currently the lowest it has been in years. The map on the left, you can see different colors here. And when you see the red color, that's the area where we have the lowest life expectancy. It ranges around 75. It's a small pocket in downtown Seattle and also South County. And then you will see dark blue, which is around the University District in Seattle. That has an average life expectancy of 90 years. So in a matter of few miles away, there's about 15-year difference. I would like you to focus on the top right graph now. You can see life expectancy differences by region. East by the blue or light blue line on top. That's the east side of King County. And then notice the bottom line, that's the purple line, that depicts the South County. And it has been declining over the years, especially during the pandemic. So you can see, depending on geographic regions of King County, there's a vast difference in life expectancy. Now, when you focus on the bottom right, the teal or green bar graph, you can see unacceptable disparities in life expectancy play out by race and ethnicity. Life expectancy is lowest among Native Hawaiian Pacific Islander in about 68, 69, and American Indian and Alaska Native around the same range. So this is a stark difference. It's about 12 years less than King County average. And the trending down in recent years. So this is not a good trend. And Black residents are also significantly lower than the average King County life expectancy. And these are tied to unequal access to opportunities for health and well-being. So here's one more data that I'd like to share with you. COVID pandemic death data are also revealing of stark health disparities and racial inequities, both regionally and nationally. Across King County, overall death rates rose by nearly 7%, and life expectancy decreased by about a year during the pandemic compared to before the pandemic. All subgroups experienced an increase in death rate from all causes. But the greatest increases in death were among Native Hawaiian Pacific Islander and American Indian Alaska Native population, just like what we just discussed the slide before. And Black and Hispanic Latinx residents also experienced very high rates. Now I'm going to pause here before we move on to the public health 5-year strategic plan. For any questions and comments so far. Yes, William or Bill?
Mia, what is the interface that you have with the individual medical healthcare medical market system as opposed to the population system that you essentially generate?
With Public Health Seattle King County Services, you mean?
With the non-public health medical market system that is the...
How we as a public health department interface with the healthcare sector.
How?
Yeah, so as Kathleen explained earlier, Before I took on the interim health officer role, I was directly providing healthcare. And Public Health Seattle King County is unique. Not all health department does this, but we actually deliver healthcare, like primary care, dental, sexual reproductive health, addiction medicine, and a lot of different varieties of healthcare. And so we are also healthcare providers. We're federally qualified health centers and taking care of people without insurance, uninsured, people experiencing homelessness. We also run mobile medical services and street medicine team to ensure that people on the streets are also getting care in a trauma-informed way. So we are delivering services ourselves. And as a leader in public health and also as an internal medicine physician, I also have a role in connecting with my colleagues, healthcare sectors. And so I've been doing a lot of partnerships, and I've been connecting with my colleagues, whether it's through University of Washington, and we also have residency programs that we continue to nurture the partnerships to work in our clinics, like Swedish Family Medicine Residency, Virginia Mason Internal Medicine Residency, Seattle Children's Pediatric Residency, and University of Washington Addiction Medicine Fellowship. So they're all part of our contract within our service. And then lastly, I will mention that Public Health Seattle King County has been garnering a lot of grants. So one of which is a large HRSA grant. And when we get it through the federal government, the majority of that grant is distributed to, say, 17 subcontractors who deliver service to people experiencing homelessness. So basically, we play a role of distributing funding that we are able to receive through various different grants and levies, so that we are enabling our partners and community partners to do that service work with us in healthcare. So I hope that gives you some example of our interface.
Is there any advocacy for expanding public health awareness in the medical school and nursing school system and with the legislature?
That's a great question. And I liked, it's a robust discussion. I think we would want to continue after we finish the strategic plan, but I will just say, yes, we do. and one of the themes that we will share the second half is that collaboration space where public health wants to collaborate even further with our healthcare sector and our community partners, because those three sectors and the integration of it is key to strengthening our population health,
Right.
and that strengthening our position and capacity to be better prepared for emergency preparedness in the future. So I think it's a good strategy, and I would love to talk more. But you're right on, because that's part of our second part of our discussion, and we would love to have more a conversation with you after the presentation.
Thank you.
Any other questions before we move on to the strategic plan?
I did see Consuelo's hand was up.
Oh, okay. Great, thank you. Consuelo?
I was actually going to ask the same question about how are you interfacing with other stakeholders, but to carry on that, have you do you seek a role for the single payer universal health care movement within King County Public Health? Not to put you on the spot.
I'll invite MatIas to speak also, but I'll just start. Because we're government, we're public health department, but we're part of the government. And we don't, I sort of told Kathleen this earlier, but we are not advocating for any specific cause. We're informing, and we love that you are in the space of equity and advancing health. We understand the causes I think we, as a government, we play some a role of being neutral. But MatIas, please feel free to add. Yeah.
Yeah, thanks, Mia. Just in addition to that, I mean, we have played, with the Affordable Care Act, we were very supportive actually as a county of the changes that were happening there. And then we were one of the leaders nationally in terms of signing people up for some of the new options and expanded Medicaid options that we had here in King County in our state. Also, there are things that can get into our legislative agenda and then that we raise up and we advocate for at the state level. So one example that's specific to access to care, we know that undocumented individuals do not have access in our hadn't had access in our state. So there is a new program that was passed, and that actually came through a lot of advocacy. It was a proposal originally really that grew out of King County and from our department. So there are things that we do get behind, but as government, it becomes, we have to have it go through the county legislative process. So it means getting the county executive and the county council to support whatever it is that we want to do.
David has his hand up. David, you're muted.
This will be the last question before we move on. Do you have much association with Seattle's network of community clinics that goes way back, like Country Doctor and International Health Services?
Yes, we do. So especially Community Health Service Division is the largest division, and not only do they provide direct service, but the other half of their work is partnership. And one of the important partnerships, the community health center partnerships, we provide funding to pretty much all King County community health centers, including Neighbor Care, Health Point, Country Doc, CMAR, and other folks. So there's a whole list of them. And we work closely, and an example is during the COVID pandemic, we held town halls on a regular basis to bring them in, to inform and update them with the guidance that's constantly evolving at that time. So we are trying to support them in various different ways.
Great.
All right, so we're gonna move on to the second half, and I'm sure we'll have some robust discussion after that. Okay, so MatIas, you wanna start us off with the strategic plan?
Sure. And, public health in King County as a health department, we hadn't had a strategic plan for over 15 years. So coming out of really the worst of the pandemic, and I would also say our declaration of racism as a public health crisis, we had a lot of which we made in 2020. There were a lot of learnings and things that really transformed how we worked with community. We were able to work and serve the community. We were able to really transform programs. We were able to add tons of staff. Unfortunately, many of them were temporary and then left the health department. But there were many things that we were able to do that we wanted to incorporate and make it part of our DNA moving forward. So I think really the strategic plan was an opportunity to really ingrain some of these lessons and the way that we do our work moving forward. So really, this is our roadmap for the 2024-2029 period. In terms of, if we go to the next slide, for us, racism and also our equity work is foundational. There's a long history around this, and I've been fortunate too. I was the director of the first county office that we established in 2015. I was directing that office out of the exec's office for 5 years. One of the first jurisdictions to really actually start equity work at a government level. We started back in 2008 in King County under the leadership of our executive, Ron Sims, and it was an effort that was supported and facilitated through the public health department, really looking at the data that Mia was referring and talking about, that really we have, although such a wealthy And the numbers overall, when you look at them in aggregate, our population's doing really well. We actually have, when you start to break it down, some of our inequities that you see are among the biggest in the nation, just given that some of our wealthy and especially rich and predominantly white populations are doing so well. And then our communities of color are in a similar situation as we see in other parts of the country. So then you actually have very big gaps. So this is really central to what the work that we should be doing. We did declare our Board of Health, our King County Executive, our Public Health Director in mid 2020 in response to really the movement for Black Lives, declared racism as a public health crisis. So even though as we're winding down from the worst of COVID-19 and the pandemic, we made our commitment to our anti-racism work central to our work. And it's something that you will see permeates every part of our department and also our strategic plan. We go to the next slide. Just want to cover, I know this might be small, so you might not be able to see everything, but just want to give you a flavor of a couple of the frameworks, because our plan does reference some of the things that are really foundational and essential for public health. The figure on the right are the 10 essential public health services, and really with equity at the core. And really this work around assurance, assessment, and policy development is central to the work that we do. And then on the left side is a framework that actually Washington State has been a lead in terms of public health and developing this, and now has been adapted also at the national level, which are the foundational public health services. And what you see at the top are the foundational areas that health departments should provide. And there's areas like communicable disease, chronic disease and injury prevention, environmental health, maternal, child, and family health, and then access to health services. And then supported by some foundational capabilities around policy, around partnerships, around emergency preparedness. So these are, there's been a lot of work in recent years to really define what are the core and essential services that public health should be offering. We are fortunate too that and given a lot of advocacy that has happened, we do have supported through the legislature, a funding source now that didn't exist. Many of the health departments around the country are under resourced. So we do have what's called our Foundational Public Health Services funding that supports work in local health departments at the state level and the State Department of Health. And also money goes to tribal partners and governments as well. So we do have now a mechanism in place that has helped us to further support some of the basic infrastructure that health departments need, which has been necessary because we have had, given some changes in the budget at the state level in particular in previous decades, that we now have a more stable funding source. Pass it over to you, Mia.
Public health, sorry if you can't see all the text here, but I'll explain what it means. Public health is moved through phases with different foci, including public health 1.0, 2.0, and 3.0. Just going over this timeline a little bit, public health 1.0 started really late 19th century and all the way to maybe mid to late 20th century. That was the era when it emphasized prevention, such as improving sanitation, food and water safety, and developing vaccines and antibiotics. So life expectancy did improve with those measures. And moving to public health 2.0, this was shaped by the 1988 Institute of Medicine, the Future of Public Health report, which emphasized core functions of governmental and public health agency capacity. And this was the era when chronic diseases were emphasized as well, in addition to public health 1.0 emphasis. And that was the era when HIV/AIDS became prominent, and that got added So there was an augmentation of public health role in that space. As we moved to Public Health 3.0, that was the time when the examination of social determinants of health really got elevated, and the prioritization of cross-sector collaboration and community partnership really got emphasized, and it is continuing, as you will see throughout our discussion here. And more recently, there is a conversation about Public Health 4.0, which is not shown here, but it adds global health and equity perspectives, especially advancing root causes of poor health, such as structural racism. And then you'll see the upper right figure. This is just one of many images out there showing key factors that contribute to health and well-being. And you can note that healthcare contributes 10% in this diagram, but in some other sources that you'll see the healthcare in a form of clinical care contributes only about 20% at most. So importantly, when you look at the rest of that diagram, you'll see that genetics, individual behavior, social and environmental factors are leading drivers of health and well-being. Now, I wanted to share this paper with you. Earlier this year, Johns Hopkins Center for Health Security published a federal policy analysis underscoring the critical need for collaboration across healthcare sector, public health, and community-based organization that I mentioned earlier in response to William's good question. And this policy analysis really captures that concept. So this analysis is consistent with lessons learned from Public Health 3.0 and the pandemic. And it's meant to strengthen healthcare systems and emergency response capabilities to better prepare us for the future. This also comes with recommendations that are grouped in 3 key domains that emphasize, sorry, I advanced this slide, but here we go. So there are 3 key domains that it proposes in terms of recommendation. First is funding and payment model reform. And I think this group probably knows this really well in terms of how important it is in terms of funding and payment model reform in order to advance our health. This includes reform of CMS reimbursement for primary care and care coordination services, as well as public health activities. And they advocate for better compensated and integrated system. And the funding structure, payment model, all those need to be reformed in order to compensate these services better. So the second domain talks about the importance of data and information exchange. You may have heard that data modernization is an important priority. And it's a priority for federal government, state government, and local government. And effective and efficient bidirectional data sharing between healthcare sectors and public health is critical to data modernization. So we do need to make sure that this is happening in an efficient and effective way. And now the last and the third, the domain that this policy analysis stressed is that healthy and strong workforce. The workforce and our staff really, they're the ones who deliver essential service to our community that keep the community safe. So it is vital that we ensure that we are able to recruit and develop a workforce for the future. And of course, this is tied to funding. And as I mentioned without adequate and stable funding, it's hard to do this work. So a lot of things are interrelated here. So please feel free to read this policy analysis when you get a chance, and I think it will be very informative. Now, so pivoting back to the our public health strategic plan, this is our public health Seattle King County vision, mission, and values. And given the background and public health framework just discussed, this strategic plan guides us to where we want to go and how we plan to get there over the next 5 to 6 years. And as informed by the engagement and current state analysis, a group of 50 staff and community partners co-created this vision, mission, and values. So this is not just our department work alone. This is with our community partners co-creating this. And just to briefly go over, the vision paints a picture of the future we are working towards. And the mission defines public health's role in achieving this vision. The values describe how public health will achieve our mission, which is by equity, leadership, collaboration, community partnership, accountability, and working upstream to address social determinants of health and root causes of health inequities. And MatIas, you wanna take over?
Yeah, so yeah, and we'll have a couple last slides here, and then we'll open it up for discussion, conversation. So this is our priorities, and this, as Mia said, we actually did a lot of engagement. We gave all our employees an opportunity to talk to us, and then talk to hundreds of organizations, and then have these shorter or smaller co-creation processes with took all these mornings to come up with the text that you've seen already around the vision and the mission, and then also get clear on the priorities. Here you will see at the base of the tree is anti-racism, and equity, and that cuts across everything. At the bottom there, you have really the foundation, which is around workforce and infrastructure, information, impact, innovation, and partnerships. I'll get into those a little bit more here in a minute. And then the two that you see above ground are climate and health, since this is really, the existential threat that we have to health. And this is going to be, we see that, of course, for the next 6 years and beyond, will continue to be a threat, and one we have to be putting maximum attention to. And then also, there's a series of emerging threats to community health and well-being, and I will cover these as well here. So if we can move into the next slide, Mia. So these are an overview of the priorities after all the extensive work that we did with our partners. So on the left side, you see cutting across there is anti-racism, and equity cuts across everything. At the top, information, impact, innovation, it's really around policy development. And really, we highlight anti-racism policies too, and developing things like policy briefs and other things that highlight that commitment. Our work around data and informatics, we know that there are a lot of antiquated data systems we need to modernize. Also improving the disaggregation of data, which we've done a lot of work with. Some of it are data that we control, but also working at the state. We do a lot of, this is where we also do some advocacy with the State Board of Health and others to have better data that also our communities can better see themselves reflected in. And then also around communications, a lot of things around language access, for example, health literacy, and also just timely, effective, and accurate communication, especially as we're dealing at a time now and in the heels of the pandemic of a lot of distrust in community in terms of government, and which really hinders our ability, for example, around vaccination and other things. We need to really be focusing on these, especially those communities that have been most marginalized. And the next row there is includes workforce, internal collaboration, and emergency preparedness. Those are things that really are key to just our infrastructure. Then there's work around community partnerships and cross-sector partnerships. includes things such as we have groups that are prioritizing. We have a group in the department that focuses specifically on the Black population. We have one on the Latinx population. We have another group in the Pacific Islander community. Also, a lot of work that we're doing around improving our contracting and making it more equitable so we can resource organizations and community better. A lot around the cross-sector work is also expanding, doing work as an academic health department. So we do a lot with the University of Washington, with others. But then also there are opportunities to work together to across sectors to really address racism as a public health crisis. And then the emerging threats that really are the ones that we're focusing on now include community well-being and youth behavioral health, gun violence, overdose prevention, and health of people experiencing homelessness. So these are the things also when Mia was showing actually some of the leading causes of death. These are issues such as overdose and gun violence are really leading causes, and where we see some of the big jumps and deaths are in those areas. And then the final item there is climate and health. So I think with that, we're gonna, well, I'll turn it back to you, Mia, for the last slide.
Yeah, I think we completed our presentation. It's a good time for Q&A. We'd love your questions and comments at this time.
So I've known Bill Bronston for 55 years now. We go way back and we've been in many trenches together. And he's been the leader of many successful and impactful campaigns for healthcare justice. He spent some time as medical director of a couple of sections of the California State Department involving health. And I got a screen share of a book he wrote called Public Hostage, Public Ransom. And this is worth reading. I think it's mostly about Willowbrook State School in Staten Island, New York, that a group of us were involved in shutting down this institution of 4,000 people who were disabled either mentally or physically, and were not getting any sort of education or physical therapy that they needed. So this was something that through a struggle and a lawsuit against the state of New York in federal court, Willowbrook was closed, and it was a landmark in the Americans with Disabilities Act. So I'd like to have Bill moderate the Q&A discussion, and please raise your hand if you'd like to contribute or ask a question.
I'd like to say something to begin with. That is that this is the first time that PNHP and the single payer movement have seriously looked at their relationship to a population healthcare system administered by a public health professional community. This has been missing for 50 years. And if we're going to have a fundamental cultural change in the field of healthcare, we have to move from individual medical services that are for sale and profits over people to a public health population-based system. So one of the things that I was curious about was each of you that are watching this show, this interaction, have some connection or other to the public health system. And I'd be interested to know where you interface with the public health system or not. And the other thing is that I'm very anxious for you to look at the actual concrete clinical model of exactly what Mia and MatIas have laid out in outline in their slideshow called ourhealth.pub.public. And what that is the most advanced model of a comprehensive population-based system grounded in public health administrative leadership in the world in writing. There is no single payer model in America in writing that is advanced as this ourhealth.pub a piece, which was crafted over 1 year every Saturday for 2 hours by 40 of the top people in healthcare policy in the United States. So I urge you to look at it, especially Title 8, because Title 8 deals specifically with the linkage between local public health, state public health, neighborhood assemblies, and the delivery system. It deals with every single issue that the two speakers spoke today and outlined in their overheads. And you'll find it immensely inspiring, and I hope that you'll use it as a very significant hammer in all of your conversations. So I'd like just to have as many people as possible on the call. There's 11, 12, 14 of you, 12 of you. Say something about how you're experiencing this remarkably inspiring, powerful, unique relationship to our effort to change healthcare in America. From where you sit. Questions, comments, recommendations to the two speakers, whatever, because obviously we need to be welded together, profoundly.
Emma?
Yeah, I'm not sure if I know if I can respond to that. I just again, I just know that there might be some cuts coming next year, and I was just wanted to speak to or ask about the issues of funding for public health. Do you have concerns about funding cuts the next year or so, and how would those gaps be filled for funding? Do you talk to healthcare workers who are working at the clinics who might be, have concerns about the clinics being closed, or what other services that you feel might be impacted next year? So, thank you.
Great, I think I can jump in and address that one, and then I think maybe we can go back to also the great question that William Bronston brought up too. But around the funding, yes, we've had, and this has been a long time coming, there's been a structural funding gap for public health in terms of what's called not all the funds, but what's called the general fund, which is the discretionary fund that the county gets, that there has been a cap that has limited itself to 1% growth, that hasn't kept up with inflation and with population growth. So that has been, and we're also limited by the state legislature from increasing and staying up with, inflation. So the good news in terms of this particular issue, though, with our clinics, was there was a lot of concern. Our employees are very concerned. Labor is very concerned. A lot of community partners are concerned. It's a $35 million general fund shortfall for 2025. So what the executive was able to do, our county executive, Dow Constantine, now has been working on a new opportunity, and I think it's getting very close to being finalized, and it will be announced as part of the current budget cycle. So it involves working with Harborview, the University of Washington, and it would be an option to be able to fund starting in 2025 for the public health clinic. So it's really using some taxing authority that the council has, but it has to be an agreement. So in a nutshell, basically, the University Harborview is a county-owned hospital, and there's some taxing authority as part of that. So the county has been working very closely, and also in partnership with the county council, the Harborview Board of Trustees, and UW Medicine, to really develop a proposal, the details of a property tax that again would go into effect in 2025. I think those talks and those negotiations are happening, and I think they are. There's very good communication happening there among those parties, and there would be always in September is when the executive announces his budget that goes over to council. So there is an expectation that very soon there will be hopefully included in that an update with the funding option for public health that would include the clinics. From there, it then goes to council. Council tends to approve the budget before Thanksgiving to then be implemented for 2025.
Mia, do you want to weigh in on this?
I think MatIas summarized that very well, including the timeline. So yeah, more to come, but announcement about to happen from the Dow Constantine's office, and then the council ultimately has to approve.
Let me make a lifetime organizer comment. If you're on the defensive, you lose. The only way to change the shortfall is to go on the offensive and to massively show that literally 1/3 of all the money that's currently going into the medical market system is for middlemen. That has to be ended once and for all, which will free up nationally over $1 trillion. And I'm sure, as in Washington state, like in California state, somewhere in the billions of dollars that would be freed up if you had a population-based healthcare system. And so even though your government, we are community, and the community really has to rise up to support you and to demand that you look at the need for going on the offensive about the budget. Because the real issue here is poverty. Poverty cuts across everything. Poverty is what's around homelessness. Poverty is around what forces people to learn to use third-rate Medicaid services that fund facilities, not people or families, from its origin, which is barbarous. Consuelo? You're muted, hon.
Yeah, I'm sorry about that. I actually especially tuned into this because it was public health, because I see public health as being so essential to the health and welfare of any population and of our nation. And in fact, in countries that have robust single payer services, they generally tend to have robust public health because they believe that health is essential to their population as opposed to profit. There's my plug. But in terms of my own feelings about how we get public health engaged, I actually am going to be giving a poster presentation in Yakima, I believe, at the Washington Public Health Conference. My poster was presented as to why public health should be engaged in the single-payer universal healthcare conversation.
Good.
And I would be very interested in having Bill, you and other people, if you wouldn't mind, including our esteemed speakers, take a look at my little poster. And if you have any feedback, I got experts at the door here.
How can you email it to all of us, or email it to David and have David?
Would you guys mind taking a look at it? It's almost done. It's going to be done like in the next 3 days.
Dave, can you send it to everybody?
It'll be included when I put the video on YouTube.
Okay.
But I feel that would be I'd really appreciate that, because I feel like I have all these experts here that could really give useful feedback on it.
Terrific. So
Thank you.
She only has a few days, so if you could email it to us just on a mass email, that'd be helpful.
Yeah, I can do that too.
You want to speak first, or do you want James to talk?
I think I raised first.
Okay, go ahead.
Yeah, I know there's political problems for you guys speaking out much in public about which way you want the healthcare system to go, but is there any way that you could help push an inside-outside strategy, like helping us grassroots people with our work? And also, we've got Pramila Jayapal as our congressperson in this area, who's like almost number one in the country of taking care of health. Got the improved Medicare for all bill, and she's involved in a bunch of other health stuff. Is there any way that you can list her off it to put some pressure on whoever helps fund the public health department care? Because I think we really need to beef up the public health finances as much as possible.
Could I suggest the way to get to that would be to invite her to come to speak to your top 40 or 50 people in the department in terms of talking about collaboration between what you're doing and what she's doing, which is really the cutting edge of what's happening in the country. And then look at our health. You'll find it very, very powerful. But there's got to be exchange, conversation between your top leadership staff and the concept. Everything you've said on your outline screams for single payer healthcare. Everything, and it just has to be articulated. And the problem is that we're fighting against the four largest economic cartels in the economy: pharmacy, hospital, drugs, and medical devices. That's what's stopping us from having a moral imperative for healthcare. James?
Yeah. Okay. Just briefly. First of all, I found your presentation incredibly inspiring. And my concern is I'm in North Carolina. We are so far away from that it's crazy. I mean, our public health system is so underfunded. It's just nuts. I don't know how we get to where you are, but I wish we could head in that direction. And I really agree with what William said about this.
Who else has comments? I'd like everybody, if possible, to say something, and not just sit. Yes, Mindy.
Well, I just came from a fundraiser this afternoon for the Washington State Budget and Policy Center. And I think they'd be a really good resource for the research that they're doing, and particularly they have, really strong racial equity foundation as part of their underlying values. And they're doing some really good work in trying to raise economic possibilities for people. So, I mean, I'm retired now, so I don't have a lot of contact, speaking to your comments, William, with the public health department, but I really appreciated them when I had my little office, and there was the vaccine program for children. I mean, it was just amazing to actually have that possibility of providing vaccines for children. It was a very well organized program. They were really careful about the tracking and the reporting, and making sure that the vaccines that were provided were at the right temperatures in the freezer and the refrigerator. And I mean, that was my chief interaction in private practice with the health department. But it just kind of gave an example of what a government and public sector can accomplish for people that may not have all the resources. So anyways, I guess the Washington State Budget and Policy Center is going through a shift in leadership right now, and I think they're also looking to collaborate with others as well. And so anyway, I guess I'd put in a plug for that.
It'd be interesting if you, David, and Pramila were able to put together a conference where Mia and MatIas could really lay out their strategic plan to a larger audience, to a non-governmental audience. It's a two-way street. I mean, on one hand, we want them to know the scope of what we're talking about. On the other hand, they've done all of the thinking in terms of breaking out what a population healthcare system should be like and the moral imperatives behind it. And we've got to get to 100, 200 people with that presentation for a half a day at least in order to, milk this thing perfectly.
Well, before the pandemic, we used to have our monthly meetings at UW in one of the big halls there. And Camilla, participated 2 or 3 times in that. So that would be great to have. And actually, one time with Amy Goodman, we got 800 people packing that the Kane Hall there. So I think what you just suggested would be really something to work for. And we've got in with UW through our Students for a National Health Program chapter there, and John was on the program earlier, who's like the head of the medical students over there. So you guys could come, and I'm sure that would attract Pramila to show up, at a time that
up front.
Congress isn't in session. So, that's something that would be really great, particularly after the election when we can see what opportunities, if any, we have with maybe a new Congress. So
poverty, climate, and healthcare are the three fundamental issues to transform America. And what the public health system is all about is democratizing the culture. Because what they're talking about is a public health system that's based on a democratic society. You can't have a totalitarian, corporate-driven society and have a public health reality. You can't.
When I did my MPH, I focused in on vaccine hesitancy, just kind of fell into it for a very weird reason. And I did note that King County is, and Washington State as a whole, is one of the highest rates of vaccine hesitancy of any state in the United States, especially in BIPOC communities. And I won't name any names. I'm wondering, do you guys feel that the outreach that King County has been doing recently has had some success? I will say that I have not gone to the data recently since COVID to take a look.
Yeah, you know, with around vaccination, if we look at the initial dose where we actually had the highest intake, and also generally and also nationally, we were able to achieve over 80% uptake across eligible groups across all kind of geographic areas and racial and ethnic groups. So I think, and that was done with very intensive work. If folks know the concept of targeted universalism, you have a universal goal, but you can't use a one size fits all. You actually have to work, with the East African community, you have to work with Ethiopian, Somali groups, with Eritrean. So we did that, and we had actually the resources to be able to do those kinds of things, and we were actually quite successful. So I think when we do have the resources, we're actually able to deliver. And part of our approach is really, we have some of the information, but we work with amazing community partners. We have a set of community health board coalition that doesn't exist anywhere in the country. We're very fortunate with some of the assets we have in community. We have 15 health boards from the Black community, from Vietnamese, Somali, Latinx, cutting across group, and then other groups as well. So we are able to do quite a lot in our area thanks to just the great leadership and strong community-based organizations that we work with.
I'd like to urge the two of you to be aware of something which you may be aware of, but the Affordable Care Act requires by law that every single nonprofit hospital in America produces a triennial comprehensive community health survey to identify the negative outcomes in their catchment area and how to fix it. That if you began to look at those documents, which nobody looks at, they're required by law to be shared. But these contracts are set up with people that are taking the money, but the information is not getting out there. But it would be crucial in terms of your planning to consolidate all of those nonprofit reports, surveys every 3 years in order to look at how you could connect with them. It's just amazing. I'm working here with an MPH student who took one of the major organizations, Kaiser here, and compared it to the Our Health model to look at the shortcomings in it. What they're talking about social determinants, but then their solution is to give grants, maybe $1 million to community-based organizations that change nothing. In the meantime, Kaiser is becoming richer and richer and richer, producing more and more clinics and hospitals in out of the area places where economic development is needed for the wealthy. So this is really a powerful tool that nobody is aware of, required by law.
So I just put in the chat, Bill, we just completed this, which was our CHNA, our Community Health Needs Assessment, working with hospitals. And next up is we're working on what's called the CHIP, the Community Health Improvement Plan. So then it's the strategy. So that's what we are doing here in King County. Yeah.
Excellent. Allison, did you want to say something?
Yeah, well, just a little bit. It's very interesting to hear this discussion. I'm actually in Friday Harbor, which is in an island on in the San Juan Islands, and we're a small rural community. We do have what's called a hospital, which is more like actually a clinic. And what I found was that I was retaining my connections with Kaiser, which I kind of enjoyed, but I discovered that when I had an eye infection here on the island, where I'm retired now, I would not be able to get an appointment in Seattle for maybe 3 days. I wasn't allowed to deal with it in terms of getting a prescription, maybe with some sort of video connection. And my daughter, very fortunately, has medical connections, and she was able to get me a local appointment, which I had to pay for. But it was at that point that I realized what we really need is Medicare. And fortunately, since I'm retired, I can get Medicare. But you know, it could be so much better for everybody. I discovered, you know, Kaiser will not. It no longer does services on San Juan Island, and that's sort of their prerogative. But what we really need is a system that has medical services for everybody, regardless of where they are in the country.
Exactly.
And it's just an example of what we need. And our problems here are rather different from yours. We don't have large populations of, you know, well, actually we do, and but they're a little different from what you get in Seattle. But anyway, it's just really interesting to hear what you have to say and the kinds of problems you're dealing with in Seattle. They're rather different, but what we all need is essentially Medicare for all, I believe.
Improved Medicare for. Craig, you lean forward. Got something on the tip of your tongue?
Well, perhaps. In medical school in Colorado, I worked with migrant health workers each summer. I spent my first 3 years as a primary care doctor in the public health service and National Health Service Corps, and I'm a retired neurologist over here in Wenatchee now. I appreciate the vast number of services that you outlined and that you're heading up. King County is very fortunate to have you in this position. And my kids and my 3 grandchildren are in King County. Take good care of them.
Well, I have a question. You know, I did some work at the Indian Health Services in Navajo country, and you know, it kind of gave me like an inkling of a little bit of what like universal healthcare would seem like, you know, in a way, because people who came there, they didn't have to worry about insurance or who was paying for it. And I mean, we have some models like that in this country. It's just that most people are stuck with the for-profit system. And I just wonder if there's some way that you guys at Public Health, have you looked at any parallels, you know, with something like the Indian Health Service and how they deal with things, and whether there's any kind of lessons to be gotten or examples. And you know, the population over there in Navajo country is really poor, and there are difficulties with transportation and nutrition and heating and
Social.
yeah. So I mean, there was a lot of problems there, and they weren't like necessarily all being solved easily, but at least there was the resource, that there wasn't this financial barrier.
Indian Health is a single payer system.
Yeah.
PA is a single payer system. Washington University and their hospitals are single payer systems, except that they're fragmented. They're not unified in a single amount of budget that is separate from the general fund of the state of Washington. And if you had a comprehensive budget in one place that was not leached by the general fund or used for anything else, defined by legislation, which may have to be done through a proposition in your state, it would fundamentally change America.
Well, I think we have to let our public servants, get their rest so they can take care of us tomorrow. So, MatIas and Mia, do you have anything you'd say before I close it out?
Well, I'm super grateful. Again, I mean, your comments are just aligned with our thinking, and I really appreciate your thoughtfulness, your advocacy, your work, and just honored to join you today and be able to share some of what we are doing, and hope there would be further partnerships with healthcare community that we mentioned during our talk. And we've seen the great success when the funding was available through pandemic, even though the times were hard. But that was a team we operated as what we called One King County. And it wasn't just King County staff or departments that we were working with. As MatIas mentioned, we worked together as one team with the community, private, nonprofit sectors. Everybody came together and worked together as one team. And I remember from day one, we operated that way. And we were one of the best health departments, and the region was healthier and more protected than most of the other parts of the country as a result of that teamwork. And I hope to sort of stress upon the importance of collaboration in our space. And public health cannot do the work alone. So especially in the funding climate that we're in. So we appreciate your partnership and healthcare sector's partnership, and we'll continue to work together with our community to bring equitable care to everybody. Thank you so much. MatIas?
I'll just be brief. I agree with everything you said to me, and I'll just say thank you all. I am very inspired by also the work that you're doing, and kind of the organizing that you do, and for us also the inside outside game is extremely important. And sometimes we can't lobby, but we can educate, and we have a lot of information as you saw it. So any way that we can work together, very much appreciated. I think we could probably sit together and speak for hours around some of the different overlaps and potential strategies of ways that we can do some things together. So just I look forward to more, I think between both me and I, just more interactions with all of you. So thank you so much.
There must be follow-up. I'll send you the copy of Jessica's paper, the two of you. I'll get your emails from David to have a look at, to see how a student looks at the problem, from a future health worker's standpoint. Thank you, David, very much, and everybody.
Okay, thanks everybody for joining us tonight, and I'll put a link up on YouTube and let you know about it. It should be available in a couple of days. And good night, and to paraphrase John Lewis, go make some trouble, necessary trouble.
Thanks, David. Thank you.
Thank you.
Thanks, everybody. That was great.
We close out in 3 seconds. 3, 2, 1, 0.